Next up, I'd like to introduce another important topic. We're going to be talking about behavioral health integration in obstetric settings. So putting much of what we learned today into practice where the rubber meets the road. Dr. Seamus Moore shared just a moment ago that women have shared they prefer to get their mental health care in obstetric settings over mental health settings. So let's see how we can make it possible on our next panel. In this session, we'll specifically be exploring integration concepts such as the concept behavioral health integration or BHI, collaborative care or COCM, all terms you've probably heard about but need some help unpacking. In this session, we'll have Joan Kennerson King moderate the panel. She's a senior consultant at the National Council for Mental Wellbeing. In her role there, she consults with primary care, behavioral health care organizations, counties, and states on developing systems of care that integrate physical and behavioral health and promote wellness. We've recently had the pleasure here at the Policy Center of working with Joan and her team at the Center of Excellence for Integrated Health Solutions on a recent perinatal mental health integration report. Joan, it's a pleasure to turn it over to you and this esteemed panel. Welcome.
Thank you. Thank you, Joy, and welcome to all of you. Thanks for being here. I've had the privilege of listening in through much of today, and I have to say it's filled my heart. So as Joy said, I work for the National Council for Mental Wellbeing, which is the member organization for providers of behavioral health services across the country, and have had the privilege, germane to this conversation, of providing technical assistance in Montana to the Meadowlark Initiative, which we're going to talk more about as one of the approaches to perinatal integrated care. And I am joined today by just an amazing panel of people who are doing work around the country. And I'm going to just ask them each to introduce themselves briefly, and then we'll come back around and hear more the specifics about their work. So I'm going to look to Steph first.
Good afternoon, everybody. My name is Stephanie Morton, and I serve as the Executive Director of Healthy Mothers, Healthy Babies, the Montana Coalition. We're a small but mighty statewide nonprofit that works to improve the health and well-being of Montana families through a variety of different strategies, including some of our work here that we'll talk about today in terms of resource and referral and connection to community-based resources that those who are taking care of kids and families in our state need in order to be able to meet the needs of all our clients and patients.
And Dr. Dressen.
Thank you. Hello, I'm Dr. Kelsey Dressen. I am a practicing obstetrician and gynecologist who works with Benefice Health System. So my primary base is in Great Falls, Montana, which is north central Montana. And then I've been very lucky to be able to provide outreach to one of the reservations, so the Rocky Boy clinic, where we've been able to integrate Meadowlark and provide some pretty awesome services for the patients there.
Thank you. And we'll leave Montana now and move over to Washington State. Dr. Bhatt.
Hi, everyone. I'm Amrita Bhatt. I'm a perinatal psychiatrist and associate professor in the Department of Psychiatry and Behavioral Sciences at the University of Washington. I direct our perinatal mental health and substance use disorder education, research, and clinical consultation center, and I'm an affiliate faculty at the AIM Center. And I provide clinical care, clinical consultation, collaborative care training, and conduct health services research, all focused on reproductive mental health and on improving access to high quality care.
And Charmaine, let's drop down to you.
Hi, good. It's great to see everyone. Charmaine Dorsey, I'm a licensed clinical social worker, and I am with the LA County Department of Health Services, which is the second largest public hospital system in the country. And we have 4 hospitals and 26 clinics across Los Angeles County. And I serve in the capacity of a Director of Patient and Social Support Services, which is a title longer than I am tall. And it really means that I get to help facilitate and lead our social work service delivery across the emergency departments, inpatients, and outpatients, which includes our behavioral health integration in adult primary care. And I'll talk a little bit later about how we've also integrated our services with our pre and postnatal population. So great to be here.
Thanks, Charmaine. And last but not least, Connie.
Hey, thanks so much for including me. My name is Dr. Connie Gill. I'm a reproductive psychiatrist by training. I'm both a professor in the Department of Psychiatry and OBGYN, and I direct our Women's Reproductive Behavioral Health Division at the Medical University of South Carolina. In that division, we do integrated clinical care, reproductive psychiatry training, and a big focus of mine is in clinical research around integrating evidence-based practices into OBGYN care using AIM safety bundles. And yeah, happy to be here.
Thank you. So let me kick us off with just a very brief. First, I want to say, Joy, thank you for mentioning the perinatal integration paper, which I wished was out on the street. It is in revision 357. Right now, as we speak, we're hoping to get it out on the street at the beginning of May. And what we did with that is just to try to look across the country at what's happening in this area of integration in the perinatal space. And so there are going to be some examples and some recommendations for what might be next steps. And we have based that on a framework of integration called the Comprehensive Health Integration Framework, which is available on the National Council website, which is really designed to help practices say, okay, we don't have to be perfect, but we could start here and we can do this one next thing to improve the integration, the level of integration that we're providing to folks, because I think probably most of the people who are listening in know that that really is the way people would like to receive care. So I want to talk just a little bit about the Meadowlark approach, and then I want to have Dr. Dressen talk about her work, which is just so important. So the Montana Healthcare Foundation, which is a conversion foundation that was formed when Montana Blue Cross went from, I'll get the right thing here, went to for-profit. And is committed to improving the health of all Montanans. 5 years ago, started a project which we now call the Meadowlark approach, which was designed to integrate services at the level of service delivery by placing a behavioral health provider and a care coordinator alongside an OB provider or OB providers in their practices. And to date, they've done that in 19 sites across the state of Montana, Benefice, where Dr. Dressen works, being one of them. And, you know, this work has been so important. And what is unique about this work, I'll be the first to tell you, and we'll talk more about challenges. We've had a real challenge with behavioral health integration on site. And so we've had to really rely on community-based providers. But what we've learned through that work is that a care coordinator is a really important component of that work. That's really what we call now the linchpin of that work. Kind of keeps everybody moving in the same direction and all the wheels on the bus. And I often say when we've got, and these resources are available to you in the Whova app. We did an evaluation last year, and in the first 5 years, we have seen an improvement in overall screening rates. Every single practice went from very little screening to really consistent screening around depression, anxiety, and substance use, which is really exciting data. And that project is also partially funded by HRSA. The other thing I just want to highlight here, and this is when we get to what do I wish would happen, one of the things that's made that project really successful, and I've had the opportunity to provide technical assistance across all those grantees, has been the partnership at the state level between the Montana Healthcare Foundation, Montana Medicaid, and Child and Family Services Division. We meet regularly, we work on this together, and on the ground there are partnerships. Those partnerships are represented. And so that's allowed us to take a much more assertive and preventative approach to some of these families who are living with multiple challenges, which I don't need to enumerate to this group. So enough said. I could talk about Meadowlark from now until probably time for all of you, even those on the West Coast, to go to bed. But let me turn it over to Dr. Dressen, because I'd love to have her kind of talk a little bit more about her role, what that's been like for her working within a program that's implementing this approach.
Yeah, thanks so much, Joan. So a little background for those who aren't familiar with Montana geography. Benefis Health System is in Great Falls, which is north central Montana, and Rocky Boy is about a 2-hour drive north. And so I originally trained in New York and Pittsburgh, so was very used to the urban setting. So had to get my head around the challenges that rural women and families face. And so I've been going to Rocky Boy now for close to 2 years, and starting out, the schedule would be, 4 to 6 patients and 2 to 3 of them who would potentially make it to the appointment. And now I think thanks to Meadowlark probably being the biggest factor on our patient load, our load is now 16 to 18 patients over a 6-hour window, working straight through lunch with a 3-month wait list. So I think the community is telling us that they're very appreciative and in need of these services that Meadowlark provides. And I think as far as my role of the OB provider with integration with behavioral health, is that first new OB visit in my mind is so important to get so many things evaluated and discussed from a physical standpoint. But I think addressing the mental standpoint, starting with those validated screenings, and with nearly every patient, I feel like my most important role is to introduce the Meadowlark initiative, the people, the resources, because one of the pitfalls that I found with my patients in Great Falls was the system was actually so efficient there that patients would receive phone calls and not know what that was coming from. And so knowing that that's part of the team approach, I think has been a big part of our success. And, as far as how Meadowlark has affected my practice, I went into OB because of the potential impact that you can make. And we know that women who are childbearing or people of childbearing potential, pregnancy is one of their main access points to healthcare. And so being able to capture them, and I don't want to say normalize, but to shine a light on the fact that from a birthing perspective, no matter how perfect or imperfect or planned or not planned, vaginal delivery, C-section, babies in the NICU, babies not in the NICU, that transition is going to be very, very difficult. And so for my birthing people to be introduced to that gateway through Meadowlark from the beginning, I think is very, very important, especially in that postpartum period to have that introduction and that foundation already set.
Thanks, Dr. Dressen. And the third piece of that sort of triad is the community piece. And so I'm going to ask Steph to talk a little bit about how Meadowlark has approached the community.
Yeah. So, in their wisdom, when the Healthcare Foundation launched the Meadowlark initiative, they included community-based connections or a community team for each one of the sites. And so Healthy Mothers, Healthy Babies is a nonprofit that has worked in local level communities for quite some time, both in early childhood, maternal child health, and then also perinatal mental health. So we came in and would start attending those technical assistance calls that Joan would lead for different grantees and sites, and started assessing, really what did folks need in order to have the referrals that they needed, whether that was a community-based mental health provider or nutrition or into Head Start, childcare, lots of different needs at this point for referrals. But what we quickly learned is that we needed something that would systematize some of this work. And really, I will say, Healthy Mothers, Healthy Babies has tried to be of service to every aspect of the Meadowlark system, but really is focused in on care coordinators. So Joan mentioned them as that like hub of connection. I think they're the hub of connection, not only for the teams in a lot of the different sites, but also the hub for the individuals who are engaging in care. And so it's just, they've got an incredible load on their plates, and they are folks who are incredibly well organized and well connected. But one of the things that we're seeing, you know, 5 years into working within this initiative was really like, we have to systematize many of these connections. And that was, you know, Healthy Mothers, Healthy Babies challenge. So whether we're thinking about coming in and providing, you know, really direct staffing. So what are folks doing in those huddles that they're putting together? Are you including community-based providers? If you have a really strong referral network, are you including child and family services within those weekly or monthly huddles? How are you sharing information, right? Systematizing a lot of that, but also ensuring like that there's no one right solution. We have to have a diversity of solutions. In the state of Montana, we're really invested in local control. And it makes it so that you also have to be really invested in listening to the care provider team in order to be able to provide what they need as a team and also reflect that within their community, right? So there was no one large solution to do it, even though that would be really lovely. But it does make it so that we get to engage with providers and their teams on a really intimate basis and figure out what that care coordinator needs in order to, you know, be able to efficiently provide those services. We have built out a program called the LIFTS Online Resource Guide, and really it's a statewide pregnancy through age 3 resource guide that now lists, I think, close to 3,000 different service and provider pairs. So in a place, a very large rural state where we often talk about the things that we don't have, we see this as a list of resilience factors, but it's also most importantly something that's accessible to both providers and then also the patients and clients that they're giving assistance to. So that's kind of one of the ways that we've been able to provide really great service. In addition to that, it's about building local level relationships. How are we bringing people together so that they know one another, but don't have to rely on them being in their cell phone to be able to make those systems level connections and referrals.
Thanks, Steph.
Yeah.
All right, Dr. Bott, do you want to talk about your work?
Yeah, absolutely. So I work in different flavors of integrated perinatal mental health care, different levels, if you will, like perinatal psychiatry access programs, co-located care. But I think for this panel, I was going to focus on perinatal collaborative care. So the collaborative care model is team-based care for integrated perinatal mental health. It includes evidence-based treatment options based on patient preference, like medication management or psychotherapy, but it also includes population health care principles. So that means symptoms are measured regularly and treatments are modified until symptoms remit. And there's very close outreach and coordination of all patients on a caseload so that no one falls through the cracks and everyone receives the level of care that they need. So central to this is a behavioral health care manager who is located in the OB clinic and is able to provide brief behavioral health interventions, but also provides a large amount of care coordination. So they conduct regular outreach, make sure no one's lost to follow up. They also meet every week with a psychiatric consultant, and they together review the caseload, making sure that treatment is intensified if it's needed, making sure that patients are graduated from the program when appropriate. And the prenatal or primary care provider continues to hold the care of the patient, which is, I think, as has been discussed in previous panels, this is what patients desire, is that their care all come to them through their prenatal provider in that setting. But now the OB provider, the primary care provider, has the support of this extended collaborative care team. So they don't have the additional burden of trying to figure out resources or figure out referral to therapy. They have it all in the clinic as part of regular prenatal care.
Thank you. Thank you, Dr. Bott, from your mouth to the universe's ears. That we would all have that. How about Charmaine? Do you want to talk about LA County and what you're doing with integration there?
Absolutely. Thanks, Joan. And really, I'm super excited and passionate about this work. We've been able to, and actually, with the collaborative care model that Dr. Bott has mentioned, I would say that we really did have the foundation of that as our guide. And it's a bit modified because we don't always have on board our consulting psychiatrist, which is an ask or a need for sure to really round out the model. But it is team-based care. So essentially, we advocated back in 2019 with our Board of Supervisors to really support the behavioral health integration implementation, which did require a staffing model because we essentially did not have this complement of team members within our adult primary care at the time. And so we did receive a very generous grant from the California Healthcare Foundation that helped us with the establishment of the foundation for how we were going to implement. And that was really helpful. So we were able to start in a few clinics, like 5 clinic pilot sites, and we were able to demonstrate and have proof of concept. And we did get that support from the Board of Supervisors to move forward. And so we were able to hire our licensed clinical social workers, medical caseworkers, community health workers, substance use counselors. We have supervisors that all work as part of the primary care team. I mean, what I would offer is that just because we say it's integrated doesn't make it so. And that would be one of the things where, you know, we were now in the space, sharing space with our other providers and our nursing colleagues. And it was really figuring out then what everybody's role was going to be. And so we did start with adult primary care initially with an idea and a hope, really a vision to be able to expand across our other clinics, pediatrics, specialty, and really have a complement of the team members that are able to address mental health, the substance use issues, the social care needs in a comprehensive way. We do have systematic case reviews with our teams that where we're talking about really the highly complex patients with our providers and our nurses. And then we also recently have integrated, we have what is called, which I love the name, but it's called Mama's. It's called Mama's Neighborhood. And it launched as part of our whole person care initiative in our state. And so it is some of the service delivery as part of Medicaid managed care, and those are contractually required services as part of the Medicaid Comprehensive Perinatal Services Program, CPSP for short, but it's a team-based model. And essentially what we're doing is we have mama's visits, extension to 1 year postpartum care with dyad mental health. There's risk stratification, care navigation, community care supports, and collaborative care. And so we're really looking at and addressing substance use, the social care, as I mentioned, mental health, and the medical comorbidities. And so it really is a unique opportunity. So while we started in adult primary care with our behavioral health integration efforts to be able to do this in a way that was helpful, we were able to then, as whole person care transitioned from grant, we were able to then integrate into those efforts for, our Mama's program, which has been really fantastic to be able to do. So it's been quite an extraordinary experience, and I think we have lots of ways that we can continue to optimize. It is, evidence-based. There are, population health, like Dr. Bott had mentioned. There's population health. The foundation of that in terms of what we're looking at. And within our state, we have what's part of the Medicaid service delivery for enhanced care management. And that's actually been a wonderful way to think about sustainability of these efforts, because enhanced care management really is looking at the really highly complex patients, and they have some criteria and algorithms. And so we were able to, because we already had our behavioral health integration efforts in place, we were able to really bring that forward and get some support through the state. So yeah, thank you for allowing me the time to share.
Thank you. Thanks for the work you're doing. Dr. Gill.
Sure. So similar to Dr. Bott, I've worked in a number of different integrated behavioral health settings, including access programs, co-located programs, using telehealth to get behavioral health services throughout our state. And really, like, through that process and understanding the different settings and the different issues that come up, and really the challenges at all the practices where we're trying to integrate, we started in parallel to that doing some qualitative research to really understand a little bit more about some of the challenges from the provider's perspective and the patient's perspective. And so using those qualitative data and then also using our experiences, we developed a program that is essentially using text message-based screening and phone-based intervention to try to systematically screen every woman that is coming through, or individual that's coming through prenatal care for mental health, substance use, intimate partner violence, and social determinants of health. And through that text message-based system, it goes to a care coordinator, I think, which is the theme here. We're all talking about how important and critical that role is, because they can address so many different facets of the person's care and their whole care, and sort of be the glue to the team. So all that information from their screening goes to this person. They're able to reach out by phone, do a brief assessment, brief intervention, and connect that person to services, including social determinants of health resources and care. And so our first work in just testing this model to see how it worked in a clinic that was doing an amazing job of screening. They had a standardized screening tool. It was well integrated. It was in their EHR. And we saw that when we enrolled people into this text message system, they were more likely to be screened, but they were also twice as likely to screen positive for the same things that they were being asked in person, but via text message, more likely to endorse. They're more likely to be referred to treatment and about 5 times more likely to actually make it to treatment in comparison to that in-person care. And that was a co-located practice. So that person could have just gone right next door to see the psychiatrist if they wanted to in person. So there is something about, I think, technology. I think you guys are going to talk more about this in this overall program. And also combined with the kind of the right person at the right time, which is the care coordinator, that I think is really bringing about some differences. And just mention one other thing about this. We saw really significant reductions in racial disparities. When Black women were screened in person and referred to treatment, they were less likely to make it to care in comparison to white women. We did not see that with this different system. They were equally as likely to make it to care, and followed up with that with more qualitative research to really understand that and tease that apart more. Anyway, so we've taken this system, we're testing it in a large study, but we've added on to that more of the AIM safety bundles, because it's really just a system trying to get evidence-based practices into a system. So I'll stop there.
Wow, that's exciting. So when we were prepping for this panel, one of the things Joy said is maybe you all could talk about the models of integrated care. And I said, not in 1 hour, we can't. But I think those of you who are, because any one of us could do a 5-hour presentation on that too. But I think those of you who are listening are beginning to hear kind of this theme, which is no matter what the model, it has to be adapted to the particular geography, to the particular population, to the particular practice team. In order to be successful. And while all of us, I think, would wish that it was a little bit easier, the implementation can be pretty tricky. And so what I'm wondering is, and whoever wants to can kind of jump into this, but all of you've been at this for more than half a minute. So if you think back to when you were thinking about, I know that integrated care is the right way to go. I know we need to do something different. I mean, I'm not going to repeat all the statistics that depress all of us about maternal mortality and morbidity in this country. So you knew you needed to do something different. If you go back to that moment, what do you know now that you wish you had known then?
Mine's really simple, so I'll just go first. I mean, we need to start with the patient and what they want, because that's the thing that's actually eventually going to get integrated into practice. Like they're the ones using it. So we really need to get their perspective on how they want these screenings, how they want their care, what does that look like? And then go to the providers and figure out what they want. And because that's where it has to be implemented, and then kind of come up with a solution that marries the two. And I wish I had that insight a long time ago.
Thank you.
I totally echoed that, the importance of starting with the patient and providers. And to add to that, the other thing I wish I had reminded myself a lot at the beginning is understanding that system level change takes a lot of time and a lot of patience. We all know what works, what's evidence-based, and we all want to implement it. But then when you're talking about changing the way that systems work and changing at the practice level, that does take time and patience. It might feel like one step forward and two steps back, but it's worth being persistent and sticking with the implementation plan.
I would offer, Joan, that while I think I am certainly one of the delusionally optimistic folks in our health system, and I dream big, and so it's really about starting somewhere and really like taking the pressure off of, even if there's this grand vision, and I think that's wonderful to have that. It is being kind and gracious with ourselves to be able to just start, even if it's sort of in this place of like not at that grand vision yet, but we've set the foundation for what that may look like in the future, and we continue to work towards that. And so that way we at least get started, and we don't get sort of stuck in a place of never giving it a go. I think to Dr. Bott's point, like healthy disruption for culture change is important and necessary.
Yeah, and there's a tension there, right? Between enough disruption, but not so much that people get paralyzed, and enough of a vision that we keep people moving forward, but also some recognizing that if you can just do one thing, start with one thing. I really love what all three of you've kind of put together. Anybody else want to jump in on that one?
I, as a person who's not a provider, but has been witnessing all of these different sites, and provider teams trying to move through these like change management processes, there is a level of like humanity in those change management processes that I've been surprised about, right? Like really giving one another grace, and like you said, Charmaine, starting somewhere and being a cheerleader. This work is really hard. And starting 5 years ago, I would not have thought this would be as difficult as I now know it is, right? And can be, but it's incredible to watch these teams move through this when they're given resources and appropriate technical assistance, and then to hear them champion the things about, patient outcomes and improving. And like Dr. Dressen said, my rosters moved from 3 to 4 patient to 16 to 18 with a 3-month wait list. And so it's really difficult, but it's amazing to watch when it comes out. And so like being in that optimistic vein, I wish I would have known how much it was going to be about also, letting the people know that are doing the hard work. It's hard work, but you're doing it really well.
Yeah.
Yeah.
So, I mean, some of you have mentioned some of this in terms of challenges. I mean, we just talked about the challenge of change management in a practice setting. I often say to people when I started out in consulting and integrated care, if I had known how difficult it was to implement screening, maybe I would have gone somewhere else to work, except the work is so rewarding that I probably don't really mean that. I'm curious, when you think about, kind of, maybe a challenge we haven't mentioned yet, how have you what was a challenge, and do you have a recommendation for others for how to overcome that challenge?
I would say, Joan, there have been a couple things. One, because there weren't a lot of sort of established models, and not especially one in terms of a health system as large as ours. So we did start somewhere, and what I would offer is that, we built it and people come kind of concepts of, we didn't have this before and didn't have a sense of what the referral volume would look like and the time commitment. And so now we're looking at, how do we now add additional staffing? How do we do that with the sustainability and justification? There's also sort of scope creep. There's like, now we have this team of people that are just, wonderful, complementary to the healthcare system. And so then the floodgates open, and everybody wants them to do all the things. And so really being able to advocate and be clear about what everybody's role is, I think, is really important. So really effective and communication often, and lots of sort of capacity building in that space. And I would say the other thing, when I'm thinking about equity and accessibility, in terms of the roles that we've been able to add to our teams, as an example, our community health workers, who we have do field, get to be the CEOs, right, of the community, and do field visits with our patients, is that, there's considerations around that, right? Like the resourcing. Are we expecting staff to go out and do that and assume that they have a car, or that they have like the transportation? Like, how are we helping to support when we say this is a really important model? Like the field visits are crucial and have been super successful, and also ensuring that our team members are well taken care of as well, similar to what Stephanie was mentioning, them that acknowledgement and celebrating those successes. I think that's important, often to keep that momentum and to just make sure that we're caring for those that are caring for others.
Mm-hmm. Yeah. Yeah.
When I think about challenges and integrating perinatal mental health, we all know that the perinatal period is a period where most people actually access healthcare more frequently than other times in their life. And it's also true that people potentially have more access to a lot of different kind of, and sometimes overlapping supports in that perinatal period. But paradoxically, that can be a challenge, as trying to coordinate with all of these different healthcare and community supports can be challenging. So that's one of the challenges I found. It again brings us back to the importance of care coordination, which perinatal collaborative care does provide. And the challenge in that is that perinatal collaborative care is a complex intervention. It's multi-component. It might be viewed as too niche by practices, and also as too much of a lift for practices that don't have a large prenatal volume.
Yeah, Dr. Bott and I talked about this on our prep call last week, that it's, on the one hand, collaborative care is such a logical intervention, and it's designed to really be on the ground. And it's very difficult to get practices to understand it and buy into it. And the volume question for smaller places, particularly in rural and frontier communities, I think is a challenge. One of the things, I'm sorry, was somebody else going to jump in? I don't want to. One of the things that, as I sort of step back and think back over the last 5 years of work, and this is kind of a front end challenge, and probably the place where I've seen maybe the most drastic change in a positive direction is, and I probably underestimated this, is I think we all come to this work with our own internal biases. And in the perinatal population, those biases in some ways, I think, are heightened because most of the people who work in this field because they care about babies. And so when the baby is at risk, it can sort of have a trying to figure out a kind way to say this, but it can have a negative impact, right, on the providers. And that provider may be, you know, the nurse in the labor and delivery room. It may be the nurse in the NICU. It may be the OB provider who can't do this one more time. And so I think for me, one of the things I've really, I've paid more and more attention to as we've gone on in this is how do we kind of, and several of you kind of talked about this, how do we help staff kind of understand their own internal landscape and then understand the landscape of the people that they're caring for in order to sort of address some of those issues. And it's particularly, you know, I think we can talk about it as being heightened across racial divides, and I think it is, but there are other kinds of divides that aren't nearly as obvious that I think play out. And as I've kind of seen really almost miraculous things happen in some of the practices we're working with, you know, we've just in terms of practices that have been caring for Native women for a long time and now are doing some really beautiful work around cultural safety and cultural immersion. And all of a sudden, and I think this is part of Dr. Dressen, what you're talking about, you don't just have 3 or 4 women coming in, you have 16 to 18 women coming in, not because you weren't doing kind and compassionate and culturally responsive work, but because the whole system around you has shifted over the last 5 years. I just think it's one of those challenges I didn't anticipate how great it was, nor did I anticipate how malleable it was with the right combination of kind of support and commitment. I don't know, Dr. Dressen, if you, I don't put you on the spot, but I don't know if you want to
Yeah.
speak.
Well, I won't be able to speak as eloquently as you when it comes to topics like this, but I know just from an anecdotal perspective, you know, working with the Rocky Boy patients, I was a little bit nervous, but I always focus back on to start with the listening, like Dr. Gill had said, listen to what the patients are saying to you, listen to their needs and what their lives are like, and trying to be extremely supportive and respectful and non-judgmental and meeting them where they are. I think we're still, from a society standpoint, fighting a lot of stigmas with regard to a lot of these topics, and a lot of internal work to be done and research to be done, which is fabulous. But I think just from the boots on the ground perspective, it's put on your listening ears, you know, going back to kindergarten, there's a lot of complexity in these topics. But when we boil it down, I think we make the most progress there.
Thank you.
I was just going to say, just in, you know, to your point, Joan, like, how do you address this on, and I think it actually just starts on the individual level. I think that's the beauty of integrated behavioral health, is that you're integrated in a system, people get to know you, they respect what you're saying. And as these issues come up, you can address them right there and then. I do a lot of perinatal substance use disorder work, and that is definitely an area where mom is demonized, they're just worried about the baby. And to be able to have a conversation with someone that, you know, addiction is a chronic relapsing remitting disease. It's a brain disease. This is what's going on. This is the whole situation. People just can look at it a little bit differently because you have that relationship with them. You know, and so I think that feels very small, but it's one-to-one. And as these relationships grow, it sort of changes. But I think that's a really powerful effect of integrated behavioral health.
Yeah, I agree. Anybody else on a challenge? No one talked about workforce. I know.
Hey,
I was waiting for workforce.
In the state of Montana, we really do struggle with behavioral healthcare workforce. I think that's happening in a lot of other places as well. But speaking from what I know, another piece of the puzzle that HMHB serves within the perinatal system in Montana is also workforce development and training. And we hold an annual perinatal mental health conference and, work to promote folks earning their PMHCs and just generally lifting the standard of perinatal mental health care and awareness in the state of Montana through lots of workforce development and also storytelling tactics. So that's been one of the pieces I think has been an incredible struggle for all of our sites, like really, I think every single grantee, and how we can help to be part of the solution with that at HMHB is a little bit of policy advocacy work and helping to continuously not only build connections on that local level to the providers that do exist within communities, but also lifting up, this is a real systemic problem. And again, reaching back out to those sites and telling them this isn't just your hospital. This isn't just your clinic. It's not just your community. This is a systemic problem. And so how can we, continue to gather information about that and move, at a state level to solve some of those issues through Medicaid expansion advocacy and pregnancy Medicaid extension, different elements of that. So definitely challenges within the workforce that we see from a distinct point in that systems level view.
How about successes? Anybody got a success you want to talk about? I mean, Dr. Gill, you talked about success. I mean, I'm still just like thrilled with the success with the text-based screening and the connection between text screening, text referral, care coordinator referral, and eliminating some of those disparities we all confront. Other successes.
I'll jump in and say, Joan, I'm going to build off the thing that was the unexpected challenge of like the malleability of the individuals that are involved in these systems. One of the things that HMHB, as we're being of service to these care coordinators and watching these different teams, alongside that, we were able to establish the Native American Initiatives program at Healthy Mothers, Healthy Babies that's led by Dr. Amy Stiffarm, who is offering cultural safety trainings that she created as part of her dissertation. And to watch the systems, be hungry for how to do their work better. And those, providers of all different kinds, whether it's LCSWs or MDs or midwives, whatever, it's really heartening to watch how much providers who work really, really hard to provide care in a difficult setting with difficult constraints to always, want to do better and do more. We have an Indigenous population in the state of Montana that's about 8% of our total overall population. But when you look at a lot of maternal and child health indicators, they're overrepresented. And so what are the ways in which we're, putting these resources alongside, and then you can always offer a resource, but you never know if somebody's going to pick it up, and watching the sites really pick it up and run with it and really do incredible systems change. I think Dr. Dressen, your all's team has been one of the places where it's just very clear how much work has been invested in the way that you think about and build out those systems of referral. And now you have incredible connections with one of the 7 reservations in the state, and it shows.
Yeah, I think it's hard to pick out an individual success story because I can see from each individual patient and from a community standpoint the impact it's had. And the one case that stands out in my mind where sort of every piece of the puzzle had to come together, was this particular patient. She was homeless. Her partner had serious mental health diagnoses, history of substance abuse, poor nutrition, and then on top of it, an extremely high risk medical pregnancy. And to to see the wheels at work with the Meadowlark Initiative and the resources that were brought in for this woman and her family was really remarkable. And to see it through from the beginning to end, it's one of those things that's what keeps you going, for sure.
Yeah, thanks for sharing that, Dr. Dressen. That was part of it for me. I'm like, there's so many sort of direct patient successes as a result of this. I would also offer that I'm thankful that we were able to really, our system was in agreement in supporting the sustainability piece, because we really did start this off with grant support, which I think sometimes, which is amazing. And as we think about what happens once that grant is gone. And so I was very grateful. I think that was a huge success to get that support. So we were able to have that proof of concept. I think also what I'm finding is sort of ongoing success is that, like, we're doing this evaluation piece or pieces to say, like, okay, how do we iterate? How do we optimize? What needs to change? And sometimes that's in the moment, sometimes over time, and change is really hard. And there's so much of it coming. And it's necessary, because how do we know that what we are intending to do is successful, or like, how's this working, and engaging with our patients, and our patients wanting to engage with us. And we got the feedback that they really do want to, in the space that they're finding safety and support, which has been their primary care setting, that they really would like all, or to the extent, as many services as possible in that one space, so that there's less of this, like, oh, I hope you get to this next resource, and I hope that resource is really, responsive. And while we can't do all the things, right, like we could do what we can to create that, and then that's one less transportation issue they might have, because they're coming in for an appointment, but they could see the whole team, or be able to address the issues in one time. So I think, like, over time, there's certainly the direct patient successes, and I would say then there's these, like, a systematic successes we've seen.
Yeah, thank you. So one more quick question before we go to our ask of the payer, policymaker, provider, partner. Dr. Bott, you are the psychiatric provider for your programs. Question is around psychiatric access. So how do your programs access psychiatric care when they need it? Montana has a perinatal, psychiatric consult access line. Dr. Bott, how about you? You staff one of those, right?
Yes, there's several different ways in which perinatal psychiatrists or psychiatric providers can be accessed. If you have, if there's a system level or organization level collaborative care program in place, then they usually contract with their own psychiatric consultant, which we've all talked about, that can sometimes be difficult to find. And then there are the state level perinatal psychiatry access programs in several states now. There's the national level PSI, psychiatric consultation line. That's another way to access psychiatric consultation. The difference there is, psychiatric consultation through a collaborative care or integrated care program can offer more continuity of care, can offer more of a caseload supervision and a population health lens to patient care. And then through the access programs, they are designed for one-time consultation, but many of them also have rolled in there the ability for the patient to see the psychiatrist for a consultation as well. And I know several organizations that use the access programs repeatedly for ongoing care of a patient as well, if they have questions that come up and follow up.
Dr. Gill?
Are we moving on to in my role in terms of are we moving
No,
on?
yeah, I'm just wondering, across the programs that you're involved in,
Yes.
I'm assuming you're not the only psychiatric provider for those programs.
No, and actually less and less. So we're really fortunate to have a reproductive psychiatry fellowship. And so every year we have one or two people come and work with us, and we can train them to do this work, and then they stay on. And so we've sort of grown a group of people that can do this work and do it in different facets. So we've been fortunate there. Like, of course, we need more people doing that. But they work in our access programs. They do direct patient care. They do a lot of trainings across the state. So in different ways, they're sort of providing access to psychiatric care.
And Charmaine, you mentioned it's a challenge.
Yes, so it's been a huge challenge. I think there's been a lot of there's been some significant, not just within health services, but our Department of Mental Health and others in terms of hiring psychiatrists. And so we do have some psychologists in our system in certain spaces, but the consistent psychiatric support is not available at this moment, which is why we're not true to the collaborative care model to the extent of having the psychiatric consultation piece, everything else we have in place. And so that's really been a challenge for us.
Yeah. Okay, so we've got about 5 minutes left. So would love to hear from each of you. If you could ask one thing that would help you, we talked earlier about how important that first step is, that next step. We've talked a little bit about challenges. If you could ask one thing of someone who might be listening, who's a payer or in philanthropy or a policymaker or a provider, what would your ask be? And I'll let you each volunteer when you want to speak here.
Say for policymakers to think with us about the really critical work of care coordination that happens when we help perinatal people navigate this very complex healthcare system, and how do we think about reimbursing for that work, and then care coordination can be part of a collaborative care model, but the collaborative care codes or billing codes were designed primarily for primary care practices. To think with us about how does this apply to prenatal settings where the billing practices are often different than primary care practices.
Yeah.
That would be my ask.
Thank you. Thank you.
I think my ask, again, boiling it down to the basics, is what would you want available for your own wife or daughter? And then I think from the efficiency standpoint, where we have talked about the importance and the access of prevention, right? And if we can get these mothers and babies on a good foundation, how much that is going to trickle down to the rest of their health span and lifespan, I think it's incredibly important.
Exactly.
Just to add to a couple of things to Dr. Bott as well, like for the payers and the role of the care coordinator being so critical, being able to bill for some of that via text and phone would be really helpful, because it is a lot of time and a lot of it is text and phone, which they're doing. In terms of policy, first of all, I just want to thank the policymakers for allowing all providers to prescribe buprenorphine without a waiver at this point. That's really great for integrated care. Yes, so thank you very much. We still have lots more work to do, which is really around prescribing MOUD via telehealth without in-person visits, really just improving access to care. And I get how tricky that is, but we need more work there. And then also policymakers, just in terms of criminalization and punitive policies around substance use and pregnancy. That is where we need the most work, because it's really a significant deterrent to prenatal care. And it also sets people up for additional racial discrimination when they start getting involved in those systems. And so yeah, those are my main asks.
Charmaine, Steph.
Yeah, so I would say I think of a few, right, that cross over the 4 Ps. But what I would say is, I talked a lot about sustainability, because that is something that is so important to think about. So for our partners, when we're thinking about any philanthropy or, support that is happening, I think really building in from the beginning what we start to plan on for how we sustain it once the funding or the grant is over. And now, we've had this taste of these amazing services, and then there's this question that, like, how do we continue this, and really sort of planning for that from the beginning. And I would say also, this could probably fall in the policy and payer, but just thinking about, there's a lot of regulations, requirements, restrictions that come with some of this. So really just thinking about, like, how we make it less cumbersome for the health system trying to implement these and provide these services.
Agree. Steph?
I will, the ask is for me, going back to what Dr. Bott said, making care coordination billable. We need to be able to pay for that critical service. It's the linchpin of so many different systems. But also I would ask of everybody, believe and know that this work happens best in partnership. I think, coming to the forum and listening to, being here year after year, we have an incredible level of wisdom and like a depth of experience. And, if you're a person who's new to this work, or you're trying to figure out who to fund, or any number of things, know that it happens best in partnership. And I've been the recipient of incredible generosity from folks who are working with moms, babies, and families. It's great to work in a space where you can assume best intentions. But yeah, if you feel alone, if you feel not sure, start being in conversation with other people and work in partnership. There's incredible knowledge already out there. You may not have to reinvent it.
Yeah, and I'll just second what Steph said. I think for me, the power of different state organizations, providers working together to gather around. Somebody said it this morning, what people are looking for is wraparound care. And if we can get those regulations aligned and the financing aligned and the partners aligned, then we can really, really soar. So Charmaine, you said you're a big optimist. That was a very optimistic, big dream statement, but that is my dream. Changing the world one baby at a time.
Baby steps, right? Joan and panel, it doesn't have to be full collaborative care model, but taking baby steps with behavioral health integration. This was a really fun panel. Joan, you're a lot of fun we're gonna bring you back to moderate another panel for sure. Panel, thank you for your expertise and your deep work bringing behavioral health into obstetric care clinics. And we're gonna be following all of your work. And we did take notes about what policymakers and payers can do. We have panels tomorrow on these very topics, and we will give them a heads up, but float some of these questions by. So come back tomorrow and listen to those sessions. Thank you again, panel, for all of your hard work and joining us today. We would like to now pop up the poll everywhere word cloud opportunity here. You can find the instructions here at the top of this slide that's up here. Go to pollev.com/MMH and drop in your keyword or phrase, what struck a chord with you in this session. Or you can text MMH to 37607 on your phone. And we would love to see what is on your mind after this session. Care coordination was a big takeaway, wasn't it? And perhaps text or tech-enabled care, Dr. Giel's feedback, which will be a nice segue into our next session. Start small, technology, yep, care coordination, buy-in. I don't know, I might put like reimbursement up there too, billing reimbursement. How do we sustain this important work? All right, well, like usual, we're going to save this word cloud. Once you're all done popping in your words here, we will save this image to the photos section in the Whova app. So keep your words coming. And we also wanted to take a moment to invite Rio to share what she's illustrated from these last sessions. So we're going to pop up. And Rio, it's unbelievable. I know I can say this on behalf of all of us that you have done all of this work in just this last hour. It's amazing. I know I can't wait to go back in. We saw an overview here on the left of some of the models and heard the word. I think, Joan, you may not have said continuum, but you meant continuum, right? You don't have to go all the way to COCM, collaborative care, but start somewhere. Challenges, what do you wish you knew starting out? So just amazing. I can't wait to dig back into these illustrations. Rio, thank you for your great work here. All right, we now get to take a 20-minute break. Actually, no, it's 15 minutes now, isn't it? to refresh and recharge. And we're going to come back for our closing panel, and you're not going to want to miss this one. It's the technology-enabled maternal mental health care session. We'll talk about collaborative care in this tech-enabled session and much more, including prevention and how tech can help prevent maternal mental health disorders. Join us back here on the main stage at 1 p.m. Pacific time. See you in 15 minutes. Thank you.